Good afternoon. Actually, I was given a very complicated title to give today. This plain film is a plain film. It is simple, but I was given by Dr. This title was fabricated by Dr. Sung-Ho Kim. So it's simple, actually. So what I wanted to talk about today is that plain films, what you do usually is that seeing your patient, you see that how big the heart is, and what the pulmonary vascularity is, and whether there is any pulmonary edema, whether there is any rapid change in heart size. But however, if you look at the plain films very carefully, not infrequently, you have quite valuable information. I want to focus on those small issues. So imaging modalities in pediatric cardiology, as you know, include multiple things: plain chest radiology, angiography, radioisotope scanning, ultrasound, CT, and MRI. Can you hear me at the back? Okay. So I was involved in writing a book 3 times in the angiography, but actually I don't see any people reading those books anymore. So which means that angiograms now in the hospital for sick children, more than 80% is for interventional procedure or additional hemodynamic assessment. Very, very occasionally or rarely for the diagnosis. And radioscintigraphy, perfusion lung scan is the only isotope scan we do. But however, perfusion scan can be easily replaced by MRI. And ultrasound, echocardiography is a mainstay. And then CT, we from time to time do, and then MRI. And actually, plain film is the oldest, but I don't think it'll disappear in the next about 30 years. So plain film is still useful. So reviewing the anatomy very briefly, frontal and lateral view. In the frontal view, on the right side is the superior vena cava and the right atrium. On the left side, aorta, pulmonary trunk, left atrial appendage here, and the left ventricle. So right ventricle is hiding in the middle. In the lateral view, so it's like American football here. So anterior is mostly the right side chamber, right ventricle going to the main pulmonary artery, posteriorly left atrium and left ventricle. So in general, anterior is right side structure, posterior is left side structure. The problem we have in infant is that this space is usually occupied by normal thymus, and then you don't have the radiographic findings shown here. Anyway, giving the overview about what you have known for a long time. So the indications shown in our requisition in hospital for sick children includes those: suspected heart disease, known heart disease, suspected complications of known heart disease, follow-up after medical or surgical treatment, and changes in clinical manifestations. So this is my recommendation to my residents and fellows, how you approach the first chest X-ray in the hospital as a cardiac patient. So anyway, that we need to look at the identification and the radiographic technique. Sometimes oblique projection gives very odd the pictures, which you should identify first. And then this is a real step. Look at the abdomen first. Site determination of sites should be the first. Like your shirts, the first button should be in the right place, and then the following the buttons will be in the right places. So situs should be determined first, and then heart position and aortic arch position, and then overall heart size and configuration, and pulmonary vascularity, and then the configuration of the aorta, SVC, and inferior vena cava, and then rest of the thorax. Okay? So here is one example: a newborn with severe tachypnea. No cardiac diagnosis, arriving in ER. What is your diagnosis then?
Anomalous veins.
Sorry?
Anomalous veins.
Anomalous veins, yes. The anomalous veins, yes. So would you mind that to put one more adjective in front of that? So what do you think that why the lungs are so reticular then?
I thought that it was increased vascularity.
Ah, okay. So that's good, yes. So, thank you for describing that. That is a good substrate we can talk about. So pulmonary vascularity, you have 6 categories. One is the normal. The second is increased vascularity. Third is decreased vascularity. Fourth is pulmonary venous hypertension. And then fifth is pulmonary arterial hypertension. And sixth is uneven, unequal, asymmetric vascularity. So the one textbook actually describes this as a kind of increased vascularity. To me, it's not. Why? The reason why it is busy is that all reticular densities mean that there is interstitial pulmonary edema. So major finding is not increased volume of blood flow, but the pulmonary venous hypertension. So it is very typical. In the newborn, you have normal heart size, no evidence of volume overload to the heart or pulmonary vessels, and then reticular pattern. And then presentation can be normal, but mostly that's a problem here. So differential diagnosis in this case is an obstructive type of TAPVC, and then viral pneumonia and lymphangiectasia. So obstructive type, in the textbook, always it says that infracardiac type of TAPVC, not always. If we have a supracardiac, and then it is in the anatomical vice, the location, you have almost identical finding. Lymphangiectasia should be included in the differential diagnosis. However, usually the reticular patterns are more prominent, and then the lengths of that small strands are longer. Okay? But I don't have any criteria, the dividing criteria to differentiate it, just the pulmonary venous hypertension and lymphangiectasia. So viral pneumonia can show a similar findings, okay? So this is another case with newborn with severe cyanosis. Anybody wants to volunteer to give a quick snap diagnosis? Yeah, there is some people giving me right answer. So this is the MR angiography. You see that very, very transverse liver. This, the right side and left side have like a bat wing coming down, which means that you have your right side duplication on the left side too. It is highly suggestive of right isomerism. In polysprenia, usually the liver is very squared, not like a bat wing like that. So in crane film, you can see in the stomach here on the left side, however, in the lateral, you have some of the haziness here. And in this case, that you have your catheter in the IVC and aorta on the same side, juxtaposition of the abdominal aorta and inferior vena cava in a patient with some reticular pattern here. So that's why that I always say, when you have a patient with cardiac diagnosis, look at the abdomen first. You have already quite significant information. Okay? So it's MRI, you have a right isomerism of bronchial branching pattern. So here are the very good telltale signs for right isomerism. Okay? So I don't have any experience that right isomerism not having congenital heart disease and then not cyanotic at all. Okay? So the patient should have cyanosis, and then horizontal domed liver with batwing appearance and bilateral minor fissures. Okay? And then minor fissure on the same side of the stomach. This is a pretty the interesting finding you can rely on. So in cytosolitus, you have a minor fissure on the right side. Stomach should be on the left side, correct? So minor fissure and stomach are on the opposite sides. In cytus inversus, you should have your minor fissure on the left side, but stomach should be on the right side. If you have your left isomerism, you can't have minor fissures on either side. So therefore, this is a very subtle finding. But however, even if Dr. Kim says that this is left isomerism or cytus inversus, I will the answer to him 10 times. It is right isomerism, and then I'm right. So this is very interesting, but the pretty interesting finding. And a part of the stomach in the thorax. Some people say it is the hiatal hernia. About 20% of right isomerism, a part of the stomach is located in the lower thorax. It is a manifestation of visceral heterotexy. Okay, so here are examples. Completely transverse liver, again. So here are minor fissures on both sides. So this is right isomerism period. So this is another case that we experienced a few weeks ago. The bat wing like transverse liver, very medially located stomach on the right side, and reticular pattern here, right isomerism with the infracardiac type of TAPVC. And actually it goes to the IVC, but there is some narrowing. The actual thing is that portal vein is here. However, this the ductus venosus, part of ductus venosus is closed, and then this area is closing. So there is some obstructive pattern of TAPVC showing some reticular pattern. A few days later, I was looking at the brain. So here you see that the bilateral minor fissures and pulmonary edema. The patient had the stent dilatation of the stenotic ductus venosus and then alveolar stent here. And then in reading plain film, I saw this, some the opaque branch-like the opacification. So in the beginning, I thought that this should be the artifact, like a cloth outside. But however, if I look at this, these are all really tree-like, and it's unlikely the artifact. So I suggested calcified thrombus in the left portal vein. And then this is the close-up, okay? So this is a CT scan before contrast injection, okay? So if we have some finding, instead of discard that finding, just to think about what could be the possibility. And then this is the after contrast injection, this is portal vein, right portal vein, left portal vein is completely occluded by the calcified thrombi, okay? So 7 months old in heart failure. So this is a typical triangular configuration with the pulmonary venous hypertension. So 7 months, what would be the differential diagnosis then? So actually the clinical information was dilated cardiomyopathy. Would you be happy with that diagnosis? Could be. Yeah. So these are the differential diagnoses. You have your left side chamber enlargement, pulmonary venous hypertension. It could be myocarditis. It could be dilated cardiomyopathy, failing hypertrophic cardiomyopathy, mitral regurgitation. When I was a resident here in 1970s, always that we just automatically say mitral steno insufficiency, rheumatic fever or whatever. But now, most of these cases are dilated cardiomyopathy. But however, if it is especially in infant, don't forget to include ARCAPA in your differential diagnosis. Believe it or not, in my career, 3 or 4 times we are able to talk about this, just including the ARCAPA in the differential diagnosis. Now that I don't see the many times that echocardiographer don't look at they doesn't look at the coronary artery origins, but I know ARCAPA from time to time, the coronary artery appears to arise from the aorta, but actually from the pulmonary artery. Okay. So including this disease in the differential diagnosis is important. Okay. 13-year-old female with chest pain and ARCAPA. So this is the post-op already. Surgery was done, and then all of a sudden heart is this big. What is the differential diagnosis then? So rapid enlargement without any obvious signs of heart failure, pericardial effusion is the likely diagnosis. Okay. So now I'm showing the chest radiograph of CT ratio, so you know how to measure it. How many people measure CT ratio in day-to-day practice? Yes? Only 5% of the audience, 6%. Okay. I will suggest it's not worth measuring. Why? I will show you this. So there's 2 examples, one patient, the other patient, 2 patients with repaired tetralogy of Fallot with pulmonary regurgitation. How many people, is there any MRI physician here? Okay. So what is the expected volume of the right ventricle in this patient and in this patient? 150, 200, 250, 80. Okay, so I will show you this. So this patient, this is MRI picture. Cardiac axis is maintained, and then this is a posterior border. It is still in front of the spine, and lateral view, you have the cardiac silhouette in front of the spine. However, this patient has the some rotation of the heart, and then posterior cardiac silhouette is overlying the spine here, and then you see that protruding there. Okay, so here, surprisingly, in this patient, CT ratio might be 55%, but the ventricular volume is completely normal. But however, in this case, heart size appears to be even smaller than this, but right ventricular volume is 190 even. So which means that chest X-ray, don't rely on the chest X-ray, especially if it is the first chest X-ray. Okay, so this is our study. Now that we have volume data from the MRI, we correlated chest CT ratio and the right ventricular volume index. Terrible correlation. I hate this one. R square value is 0.12, but still p-value is 0.003. Of course, there is correlation, so in tendency. But however, if your scatter is the wide, can you use that CT ratio for any judgment? No, forget it. Yes. So this is the same. So what it is that the CT ratio and real heart volume, there is very, very poor correlation. So you just casually say mildly enlarged, moderately enlarged, and markedly enlarged. That is good enough. When it has a value is that when you do the follow-up study in the same patient, and then on the follow-up study with good inspiration, and then there is significant change in heart size, and at the time it has significance. However, the chest X-ray alone doesn't mean that much. So 10-year male status post TOF repair. Do you see any abnormal finding here? So mild, moderate cardiomegaly. Okay. What about the pulmonary vascularity? Is it normal? Is it abnormal? Is the pulmonary vascularity symmetric or asymmetric? So this is another message really I want to give you. Chest X-ray is surprisingly very good in detecting asymmetric vascularity. However, most of the people are shy in describing that there is asymmetry, just for fear of wrong answer. But if you look at here, so look at the size of the pulmonary artery here to here, and then peripheral vessels here and here. There is certainly more prominent vessels here than here. In the lateral view, in the anterior pulmonary artery is big, and the posteriorly there is no. So you have here, can you see the airway coming down? And then this is mostly the shadow made by right pulmonary artery. This is mainly from the left pulmonary artery. If I read this one, I will clearly say there is asymmetric vascularity with significantly reduced vascularity in the left lung. Okay. So this is our CT scan. So you have your main pulmonary artery, right and left pulmonary artery, significant difference. So supporting that, so you see that the right pulmonary artery big and left pulmonary artery small. Right pulmonary veins very big, left pulmonary vein very small. Okay, so there is because of this is this pulmonary artery, this is this. So therefore, in the lateral view, posterior to the airway, you don't have a big shadow. Okay, so going back, so in the frontal view, if you see significant difference in size of vessels, don't be shy on describing that. Okay, this is the 2-year-old female with complex congenital heart disease. So the patient underwent VSD closure at 5 months, increased work of breathing. So what about this chest X-ray? You have a little bit of a pleural reaction here, and the vascularity is not symmetric. So this is a typical increased vascularity, while this is a typical pulmonary venous hypertension, a lot dirtier and reticular. If you see that, right away you suspect obstruction of the pulmonary vein in this side. Yes. Actually, we described in such a way, and then we found in the CT scan that right pulmonary vein is completely occluded, and then there is the interstitial Corliss lines here only on the right side. If we have a unilateral pulmonary vein obstruction, what you have is that reticular pattern on one side, and the other side you have a significantly increased pulmonary vascularity. Why? If we have pulmonary vein obstruction, let's say 100 cc's going out to the main pulmonary artery, only 10–20% of the pulmonary blood flow go here, and the rest of the pulmonary blood flow should go to the unobstructed side. Okay? Therefore, the other side, you should have increased vascularity. So this is a 7-month-old girl with pneumonia. I have experienced multiple cases in my career, and then most of the time, diagnosis is pneumonia. What about this? This is chest frontal and lateral views. Does anybody have an idea about your diagnosis? Is it plain film diagnosis is important? Why? Believe me, I have seen multiple cases, under antibiotics, anytime that there is a fever for 5–10 years. One example, actually that was my first case report when I was a resident, hemoptysis. And then, because of a hemoptysis, they did an angiogram to do the coil embolization of bronchial artery, and then found the diagnosis. What could it be? So here in this case, the heart is actually displaced to the left side, and then airway is displaced to that side too, and then aortic arch is right aortic arch. The patient doesn't have tetralogy of Fallot. So sinusolytus levocardia, small left lung with right aortic arch, and then you should have diagnosis. Okay, what is that? So this is the 3 months follow-up. You have a further decrease in left lung volume, and then this is the reading from outside, which means that this may represent pneumonia, but differential diagnosis would include aspiration or other congenital lesion type of things. Okay? But however, if you know the disease entity, you have the diagnosis. What is that? In this MR angiogram, pulmonary artery goes only to the right lung. Okay? And then there is right aortic arch. This is the left brachiocephalic artery. Do you see small diverticulum here? And then small vessel in the hilum. Okay? So actually, this is the left pulmonary artery. Left pulmonary artery is disconnected and very tiny, and then which means that, so here between this diverticulum and left pulmonary artery, there is a ligamentum. Ligamental ductal origin of the left pulmonary artery. In old term, unilateral agenesis of left pulmonary artery, UAPA. Okay? So in that, usually the disconnected pulmonary artery is opposite side of the aortic arch, almost always. Okay? So therefore, having that plain film is very, very suggestive of this diagnosis. Okay? So, and then the pulmonary vein on the side is very, very tiny here. Okay. So 7-year-old boy with dyspnea. Okay. So similar finding in the opposite. So you have a small right lung, large left lung, and then airway is displaced to this side. So this is not primary cardiac origin. So what is different from here is that this is a true dextrocardia, which is congenitally corrected transposition in this case. However, airway is in the middle line. Here, airway is displaced. What it means is that heart position and airway is related to lung volume. In this case, that right lung volume is small. Or differential diagnosis, the left lung volume is large. Okay? So the aortic arch is actually on the left side in this case, and then this is the MR and the A study. You have your main pulmonary artery only giving rise to the left pulmonary artery. Right pulmonary artery is completely missing. Absence of right pulmonary artery. Okay? And in an MR angio, you have your left aortic arch, and then there is the very tiny suspicious, oops. So small right lung, these are the differential diagnosis. Ligamental ductal origin of right pulmonary artery. In all the term, unilateral absence of the right pulmonary artery. Why is it blinking? I didn't do anything. So unilateral right pulmonary venous obstruction and Scimitar syndrome, as you know. And hypopressure, and if you have all this, the excluded, and then you can have a hypopressure of the right lung. It's exceedingly rare. And then in children, one more differential diagnosis is that hyperinflation of the left lung due to foreign body. Okay. So this is another case with the small right lung, and then there is the complete, the unilateral atresia of the right pulmonary vein having similar finding. Okay, so this is classic scimitar syndrome. You have small right lung, and then this is a scimitar vein coming down. Usually you have a little bit of retrosternal hazy opacity here. Okay, so this is a scimitar vein here, a little bit obstructed in this case, and then similarity between this one and this one. They gave us the name of scimitar. Okay. So this is the, if you know the presence of this entity, you can make the diagnosis from plain film. What is the diagnosis? I don't know what it means actually. Yes, correct. Absent pericardium. So if you have the frontal chest X-ray like this, and then you have two differential diagnoses. One is that pectus excavatum, and then the other is that absent pericardium. Okay? In the lateral view, there is no pectus, and then absent pericardium. So the reason why that is that the AOA and other finding, there is no reason why that the heart should be displaced backward and then rightward. Okay? So this is the MRI finding. So the heart is really rotated and displaced to the left side. And then how can you make the diagnosis of absent pericardium with MRI? Can you see the pericardium? Absent pericardium? No. So this is very, very little finding. You have a main pulmonary artery and ascending aorta. Can you see the lung tissue intervening between these two structures? Normally, you can't have lung tissue there. Why? Pericardial reflection goes all the way top of the main pulmonary artery. So therefore, this space should be covered by pericardium. You can't have the lung tissue intervening there. So this very little finding is diagnostic of absent pericardium. Okay? So this is the the left lateral decubitus, more displacement, and then right lateral decubitus, a little bit of going backward, because that it's just by gravity it displaces toward the dependent side. Okay, so going back, so I'm showing you again. If you have this plain film findings, the patient can have some chest pain or whatever, some ECG abnormalities, you just declare that it's the absent pericardium. Okay. This one also I wanted to show you, a teenager with chronic dyspnea on exertion. What is the diagnosis? You have a mild cardiomegaly and a very prominent main pulmonary arterial segment, and central vessels appearing rather large, but periphery is not large. What is the diagnosis? Yes, pulmonary hypertension. So you have your lateral view is very characteristic. You have here the trachea coming down. This is a right upper lobar bronchus. This is left upper lobar bronchus. What is that? Right pulmonary artery, left pulmonary artery. Both are big, making a big potato, and then giving rise to small sprouts. Okay? So central peripheral discrepancy is well shown here, and that is very, very characteristic of pulmonary arterial hypertension. One thing that I want to emphasize is that a lot of time the people think that if you have right ventricular hypertrophy, you should have round and elevated cardiac apex, because tetralogy of Fallot shows that finding. That's wrong. In atrial septal defect, in pulmonary hypertension, you never see elevated round cardiac apex. This is a usual cardiac apex configuration. It's very similar to left ventricular enlargement. However, in lateral view, this posterior part is okay, but anterior, the retrosternal clear space is obliterated. Okay? So actually, in our hospital, we missed the diagnosis. Not we missed, outside, the diagnosis was missed, and then actually when the patient arrived in the ER after gym class, and then the patient collapsed and died. So in sometimes the plain film, don't ignore this finding, okay? So this is just the frontal view, why that happens. In the lateral view, this is the left pulmonary artery, this is the case, okay? So another teenager with known diagnosis of pulmonary hypertension. What do you think? Is it a little bit different, or can you see that the previous case, it was pretty, lungs were clean, but here a little bit reticular. Can you agree? So at admission, the patient was given in the ER oxygen and the vasodilator because the diagnosis of pulmonary hypertension. What happened? You actually post-capillary pulmonary hypertension, giving vasodilator. Not always. You can have worsening pulmonary edema. Okay? So this is a CT scan. You see that a lot of reticular pattern everywhere, and then Colles line touching the pleural surface. So this is a pulmonary veno-occlusive disease causing pulmonary hypertension. So this is the primary idiopathic pulmonary hypertension. This is the pulmonary veno-occlusive disease. When you have a pulmonary hypertension case, if the lungs are clean, that is more likely primary, idiopathic. However, if you see this, the Colles line and reticular patterns, you should include in the differential diagnosis the pulmonary veno-occlusive disease as the possible etiology. Okay. So almost done. 16-year-old male with hypertension and right hemiparesis. Can you see that the aortic knob is a little bit unusual? It's not like a coarctation of aorta, right? It's not epsilon sign or figure of 3. So a little bit lobulated. What is the diagnosis? Takayasu arthritis, yes. So whenever you have your descending aortic shadow not straight down and then undulated and lobulated, very likely you have Takayasu arthritis. 4-year-old child with AVSD, very classic finding, before repair, after repair, in the ICU. The patient was not symptomatic. What is that? Mediastinal hematoma here, seroma or hematoma. So sudden increase in the width of mediastinum after surgery, you always should think about it. So however, actually normal thymus can have very, very rapid ballooning. If you have the patient condition prior to surgery was a cyanotic condition or very critical, and after successful surgery, even within the ICU, I have seen the case having ballooning the thymus as a normal rebound growth. But however, you should always think about the surgical complication. Okay. So 3-month-old infant with patent ductus arteriosus. What's wrong here? So what is this lucency? So pneumothorax in the supine position accumulates anteriorly and medially. So anteromedial pneumothorax, this is a common location for the pneumothorax to accumulate, okay? This one, don't forget this case. This is ICU, 8 months with double aortic right ventricle, pulmonary artery banding, and ASD stenting. So heart is big, or the pulmonary edema. Can you see here, some lucency here? Branching lucency. Those are not air bronchograms. Air bronchograms should have a very orderly pattern. Proximal should be larger and peripheral should be small. Otherwise, it's a bronchiectasis. But however, these lucencies not having tapering out, okay? So this is what? Pulmonary interstitial emphysema. It is exactly after the 1 day, and then you have more finding of interstitial emphysema, and the patient has developed a pneumothorax. Okay, so pulmonary interstitial emphysema in ICU. If we have this, the unusual tubular lucency, not even caliber, that is the almost a diagnostic of pulmonary interstitial emphysema. Okay. So this is the case with the abnormal, if I blow up here, so you see that the ET tube is 2 down in the right main bronchus, okay? So abnormal location of the airway. So lastly, This is a 7 day after surgery for tetralogy of Fallot with absent pulmonary valve syndrome. What's wrong? Right hemidiaphragm is elevated, or there is subpulmonary effusion in the right side. What would you like to do next? CT, ultrasound, or MRI? Which imaging modality would you like to use? Okay, so ultrasound is the answer. So this is the M-mode representation of normal diaphragmatic motion. So this is the right side. Diaphragm is not moving during respiration. So unilateral, the right diaphragmatic paralysis. Okay, so what I recommended is that these 6 steps: look at the identification and radiographic technique, whether inspiration is good enough or whether there is any obliquity, and then determine the situs first and define the heart position and aortic arch position. And then describe the heart size and configuration and pulmonary vascularity, 6 categories: normal, increase, decrease, pulmonary venous hypertension, pulmonary arterial hypertension. Don't forget asymmetric, uneven, unequal vascular distribution. And then you need to look at the aorta, superior vena cava, inferior vena cava, and other part of the thorax. Okay, so try not to miss a subtle clues to the important diagnosis. Thank you very much for your attention.